So good evening, everyone. Today we are having this class, and it's going to be on the radiology of obstetric and gynecology emergencies, and I will be your presenter together with Dr. Hassan. Our facilitator is Dr. Mwango. So we have a total of 7 topics to cover, or rather 7 pathologies, conditions to cover, and I'll cover the first 4, and then the last 3 are going to be covered by Dr. Hassan. So before we start with our first pathology, I'd just like to take us back to how we should carry out the normal first trimester ultrasound. And in this assessment, we are to check its location, whether it's within the uterus or whether it's extrauterine. In this case, if it's extrauterine, we know we are dealing with an ectopic pregnancy. Then from the gestational sac, we should be able to calculate the gestational age by getting our mean sac diameter, or preferably the crown rump length, which is more accurate. And then after that, you need to tell where the yolk sac is and how the yolk sac appears. And then we should be able to calculate the cardiac activity using the M mode on the ultrasound. And then after identifying the gestational sac, we need to tell apart the different the number of embryo of fetuses that we can see, and its amnionicity and chorionicity. Then after that is done, we also are supposed to assess the adnexa. So this image to the right is that showing how to calculate the mean sac diameter. So give me a minute, I let someone in.
Hello? Sawa. Haya.
Posterior and your height. So once you get these 3 measurements, you get the average, and that is your mean sac diameter. In this case, the average is coming to 12 millimeters, and that was corresponding to 6 weeks gestation. Let me allow someone else in.
Ako hapo? Oh, ndo anapita Red Cross. Sawa, sawa, niko class.
And these are the parameters that need to be set before you get your crown rump length. Ideally, your fetus is supposed to be filling a majority of the image space available. Then it needs to be taken in the mid-sagittal view, where you can visualize the spine, the crown, and the lump. So the head needs to be in neutral position in that the neck is not hyperextended or flexed. So you should be able to see fluid between the chin and the chest of the fetus. And then when you're getting the measurement, the angle of insinuation should be perpendicular to your fetus. So it is recommended that you get this measurement, and it's accurate just before 6 weeks, and you use it up to until the end of the first trimester. So on to our first condition, which is ectopic pregnancy. So by definition, an ectopic pregnancy is one that exists beyond our endometrium or our endometrial cavity. So if it's within the cervix, if it's in the interstitium, if it's anywhere on your fallopian tube, isthmus, ampulla, fimbria, if it's in the ovary, if it's in the peritoneum, or if it's within the abdomen, all these are considered ectopic pregnancies. And 95% of these ectopic pregnancies, they occur within the isthmus and the ampulla.
And then the second most commonest, but it's only 2 to 4% of them, they're this interstitial type. Let me let someone else in. So for the sonographic features that we'll get, so you can diagnose ectopic pregnancies both on transabdominal or transvaginal ultrasounds. Preferably, TVSs are recommended because they are more superior. It will give you better resolution of the internal female genitalia, including your early pregnancy. Also, something else, you'd prefer a full bladder when you're doing this examination, but this is not always the case because here we are dealing with an emergency and your patient will most often come to you without a full bladder. So in this case, we still remember that the TVS is the one that's preferable. And you know that when you're doing a TVS, you don't require a full bladder to perform your examination. So when you're doing both of these ultrasound scans, you should ideally examine your different organs or different parts in two planes, sagittal or transverse, and then make sure you've examined everything: the uterus, its contents, the fallopian tubes, which will only be visible when there's pathology, and the adnexa together with the ovary. Key areas that you also need to examine includes the space between the ovaries and the uterus, because that's the most common site of ectopic adnexal masses. And then when you're doing a transvaginal ultrasound, you can also do a bimanual examination. In this case, the transvaginal probe will help you. And having your hand over either of the adnexa, you can be able to compress the mass between your arm and the probe itself. That light pressure can also elicit pain that is similar to what brought the patient to the hospital, and that can also sort of point you towards the diagnosis of an ectopic pregnancy. If you see fluid present within your pelvis, within the porch of Douglas, you are highly advised to examine more superiorly so that you see the extent of this fluid collection.
So performed a TVS?
Hello. Okay. Sawa. Ukifika Nairobi West ni show. Okay.
Sharon, you can start by answering that.
Yes, I have performed a few.
Mm-hmm. What challenge? Did you have any challenges?
Yes, I did.
What was the main challenge?
The main challenge was it's not easy to orient yourself so well, especially if you've not gotten your main organs. So I think it first starts with how I place my probe.
That is very key. Actually, getting your side marker is important, and knowing that if the side marker is facing up anterior aspect of the patient, you're going to get a sagittal image. If it's facing to the right, you're going to get a transverse image, and that is key. Otherwise, you'll really struggle getting the images. And then what was the other? And of course, before all this, I am assuming that one has talked to the patient, gotten consent, and now proceeded on to do the TVS in an aseptic way as possible, right? So what else was the other challenge that you got?
The other challenge I got was identifying the ovaries in the adnexa.
Okay, one of the key challenges one might have is sometimes pushing in the probe too deeply. You might push in the probe too deeply into the posterior fornix, and then you really cannot see anything, or you just see maybe the fundus. So when that happens, you need now to retract a little bit, get your sagittal image, and be able to see the entire uterus. Of course, before you do the TVS, you've done a transabdominal and evaluated, ensured that the structures you're looking at are not large. They should not be more than, let's say, 12 centimeters. They should not be getting out of the pelvis more than 12 weeks, because if they're large masses, then the TVS will not assist you much. So like if you want to look at the cervix in TVS, you need to pull it out a little bit, and then you'll be able to see the cervix. Sometimes you'll not be able to see the entire cervix. Panning is always important whenever you are doing your ultrasound, moving your probe from side to side and up to down, so you're cutting sections through the structure of interest, so that you don't miss any lesion. So you don't just get one image and freeze. You should sweep first before you get the image. Then you go transversely, and then you can get your images, and then you can now, to get the ovaries is where the bimanual comes in. You can identify the internal iliac vessels. If you identify that, just more medial to it to be able to get the ovary. And a bimanual would help because you can displace the bar loops that could be covering it.
Yes.
Yeah, and again, you do it very gently, yeah, and very slowly, because if you make rapid movements, again, you might you might struggle more than you need to in doing the TVS. But again, practice really help. Yeah, and the same thing also from yeah. What about in a transabdominal? What are some of the challenges that you've had when doing a transabdominal scan? Now you can have somebody else answer that. And this is supposed to be interactive. So we can discuss the challenges and see how we can navigate that. And yeah, going forward.
Yes.
Right. So with transabdominal,
Yes.
in fact, even during my last the last time I was on call, there was
Mm-hmm.
a patient who was rather obese,
Mm.
and she came in for an obstetric scan, and unfortunately, like, we couldn't really visualize the fetus well. We had to apply a bit of pressure, and yeah, I found that quite challenging. Like, even something simple like looking for the lie of the fetus, it took quite some work.
Yeah, it can be tricky, especially if the patient is obese, and especially if they have,
Because if it is in late pregnancy, was it in late pregnancy?
No, doc, it was the second trimester.
Second trimester. Okay,
Yes.
sometimes in late pregnancy, there's an additional fat that is added at the lower abdomen, suprapubic. So that makes it even more difficult. One thing you can do is you change your megahertz. You go even lower on your megahertz. You could try that and see if you can get the imaging. That's what one can try. You can also try and remove the tissue harmonics. That
Okay.
in a way gives you can improve your depth. So you get a more black and white image. But in terms of if you want to look at the gross, at least find out where the placenta is there fetal heart? If you're doing gestational age, you may be able to assess that. And
Okay.
this the first time that she was coming for an obstetric scan?
No, she had one before.
So it was a follow-up scan,
Yes.
and what was the indication?
So they wanted to know the umbilical RI and the AFIs.
So you are not able to do that, isn't
No,
it?
I was able, at
Mm-hmm.
least the second year guided me, but I was,
Okay.
yes.
All right. So how were they able to get that?
So what he told me is that, like, just apply more pressure, and when I did, at least I was able to get the head circumference and see that the lie was encephalic.
Okay. But you realize also for Doppler, when you go to Doppler, it goes to a lower megahertz. So your penetration is better. Usually it's around 2.0 megahertz. Huh?
Okay.
Yeah. So in future, those are some of the things that what one can do.
Okay.
Okay.
Thank you, doc.
Right. Any other challenges that we can discuss before we proceed? The other thing is in early pregnancy, if the bladder is not very full and you are doing a transabdominal, pressure again helps to graded pressure, not a lot of pressure, graded pressure, to push away the bowel loops. but also it's important to ensure you are angling into the pelvis, not just directly suprapubic. You have to angle downwards. If you don't do that, then you may not also see the structure that you need to see. All right, we can proceed.
Thank you. Just to take us back a bit and expound on this by manual examination. So, Dr. Mango, you've told us that this helps you to examine the ovary better. And also, I read somewhere they said that if there's a gestational sac in the adnexa and you're not really sure if it's an ovarian mass, if you apply this by manual pressure, you are able to separate the two and you can tell those two as independent structures. So I can just add that.
Yeah, that is true. Because remember, when you apply the pressure, you're reducing the amount of tissue that the sound waves are going through. So it improves your spatial resolution, right? Yeah, quite a bit. It's the same way, like even one was doing a physical exam and you did a by manual palpation. It's the same kind of science or application or technique that you're applying at the same time. All right.
Okay, thank you. So this next set of images of one patient. She's a 33-year-old woman who presented with left lower quadrant pain at 9 weeks gestation. So we have a transabdominal and a transvaginal scan. In the transabdominal scan, it shows a gestational sac in the opposite adnexa, the right adnexa in this case. And from this, what we can be able to tell, from this structure of our gestational sac, you have the anechoic mass, the anechoic mass with hypoechoic or echogenic soft tissue mass within it. Then surrounding it, you have this thick wall consistent with a decidual reaction. And this entire structure...
Just a minute, Doc. Just a minute. So what you're seeing is a thick-walled system.
Yes.
So that echogenic ring is a gestational sac filled with fluid and what can look like, well, so you can see a thick-walled cyst with an internal echogenicity and fluid. Now that internal echogenic mass, if it has cardiac activity, then that increases your confidence in saying that this is an ectopic pregnancy, because it could still be a thick-walled cyst with a blood clot within it. And that is why the clinical setting becomes important. Is a pregnancy test positive and things like that. Ratios for this would be a what? A corpus luteal cyst, isn't it? Huh?
Yes.
Yeah. So decidual reaction, decidual, that is endometrium. So a pregnant endometrium is what is known as decidual. So if you're in that nexa, there will be no decidual.
All right.
Yeah.
Okay.
And when you get that double sac sign,
yes,
you're getting the cogenicity of the decidual and the cogenicity of the chorionic or the gestational sac to give you that double sac sign.
Double sac sign. All right. So which we only see within the endometrium. So image
yeah,
B.
the decidual is endometrium. Yeah,
okay.
the decidual is endometrium. So in image A, is A and B of the same patient?
Yes, both are of the same patient.
Okay. So what we are seeing is more of the anterior abdominal wall, the posterior abdominal wall, and then the image A.
These are the structures.
Yes.
Yes. Yes.
All right. And there's no free fluid around it.
No, I wouldn't say there's any free fluid.
Okay. But that again becomes easier when one is scanning to check to see if there's any fluid. Usually, anyway, there usually some amount of fluid in that nexa, some minimal amount of fluid, even just after, yeah. Usually is some little fluid actually. Right. And then in B?
Now in B, we're seeing the hypoechoic fluid collection posterior to the uterus. And we can also see the endometrial cavity is distended with this heterogeneously echogenic mass within it.
Is thickened and echogenic.
Yes.
So where is the fluid?
The fluid is in the pouch of Douglas. Here
So the
posterior.
fluid has sediment in it. It's layering.
Yes.
So what you have is layering fluid. So you have the clear fluid. Go more anterior.
This.
Yes, and then behind that is more echogenic fluid when you have cells, and that increases your confidence that what you're looking at could be hemorrhage. Yeah?
Yes.
Right. And then so you have the uterus, and it's very thickened endometrium.
Yes.
Okay.
All right, thank you. We'll go to the next one. So this next set of images also belong to one patient, a 28-year-old female who presented with pelvic pain at 8 weeks gestation. So image A is an ultrasound of the splenorenal fossa, and it's showing this anechoic fluid collection. And then on examining the pelvis, this is a transvaginal scan, and this shows the sagittal view of the uterus. This is the anterior wall, fundus posterior wall. And then within the endometrial cavity, we are seeing this anechoic fluid collection with internal echoes, yeah? Then anteriorly and posteriorly to it, we're seeing this anechoic collection also, but it also has internal echoes. Sorry, let me let someone in.
So I hope, Doc, you'll be getting your colleagues to report on the images.
Okay, I don't have
you want to discuss all of them?
Yes, I didn't have a quiz section, but yeah, okay, I didn't have. Maybe for today.
No. You can just give them the history and then they can discuss.
Okay.
So to make it much more interactive. Yeah. But what right?
Yes.
It's going to be central. It's not going to be eccentric because you have to look and see where that fluid collection is. There won't be a decidua around it. I mean, not a decidua, just a chorionic sac within it, because it's going to be just central, not placed implanted into one of the endometrial walls. Yeah. The echogenic content that you're seeing, again, could be blood clots, because this may be a lady who comes who is spotting in the first trimester. So that could be part of the blood clots there. But you can see that the cervix is closed. And the uterus, the wall has a normal outline. Then posterior to it, you have free fluid in the POD, not much, some free fluid in the POD, and also some in the vesicouterine area. And then around it is free. Yeah, the word collection, I don't know what it really means. Is it pus when you say the word collection, or you mean fluid?
I mean any type of fluid. Could be blood, could be pus.
Why don't you just call it free fluid?
Free fluid. I can call it that.
Yeah, because collection sounds like it needs to be walled off.
Okay.
Okay, to me, I don't know. I don't know. It's a bit vague. This is free. It's not walled. It doesn't have it, whatever. So it's a more of a specific. So it's anechoic, and it doesn't have echoes in it. Huh?
Yes.
Because what you're seeing is artifacts from the ultrasound beam that are crossing.
All right.
Those, you can see those are artifactual. Those echoes that you're seeing, they're forming a ring. They're artifactual.
Yes, that's true.
Yeah, and then the next one, so they see the same image, and you can see again, it is a pseudo gestation. It's right in the middle of the uterus. It's not eccentric. And then there's that clot within it, and there's that free fluid in the POD and surrounding it. Yeah.
Yes.
Okay.
Or
So what was there in the adnexa? A?
no, now unfortunately in this case they were not able to visualize the ectopic pregnancy. They only got it surgically and removed it. So what image A was showing, this is a splenorenal fossa with free fluid collection. So just to further emphasize that point where I mentioned that when you examine the pelvis and you see free fluid within it, it's advised that you go superiorly and assess the other potential spaces to check whether you have collections there, free fluid within those spaces.
Okay, so A is a splenorenal, though I don't see the spleen, I don't see the kidney.
Yeah, I was also not able to see that.
Yeah, it looks like iliac fossa, where you have the anterior abdominal walls and the posterior abdominal wall muscles and bowel loops, and you a little pressure. That's the kind of appearance you'd get.
All
But
right.
okay, right, all right. Has any of you seen an ectopic pregnancy?
Yes.
So with these images, reminded me of recently over the weekend we had free fluid in the uterus. It was quite
Mm-hmm.
large, and we had not really thought of the ectopic pregnancy, and we
It
actually
was it was a woman in the reproductive period
had woman reproductive period,
age. Yes. Uh-huh.
had severe abdominal pain.
Yeah.
Said to rule
Low
out
abdominal pains.
yes,
Mm-hmm.
abdominal pain, and it was to rule out acute abdomen.
Yeah.
And they I cannot remember the HSG that was done.
HSG.
Not really, sorry, the pregnancy test
Okay.
done,
Beta
or
HCG. Beta HCG.
the HSG that was done. So
Yeah.
what we saw when we did the transabdominal ultrasound, we had seen now the intrauterine fluid collection that was quite large, and we were not able to actually see the ectopic because we really looked for the ectopic pregnancy. So also there was that limitation. We had asked the patient to go back and fill the bladder, and it was almost the end of the call. So I'll follow it
Okay.
up actually to see whether it was truly ectopic because this
You, you
seems
didn't want to follow up with a transvaginal?
we hadn't done that. We didn't do that. We actually asked her to fill the bladder.
Yeah, because sometimes it may be quite difficult to have so that if the bladder is not very full and the patient is doesn't mind, I think it may be quicker to just do a transvaginal, and then you're able now to assess that nexa quite well. Was there any fluid in the POD?
No, we didn't see. So the main that was very obvious was the intrauterine fluid that was quite
Mm-hmm.
large. That's what we saw. So it was more like the pseudogestation, probably.
Okay. Was she having any vaginal discharge? Was it bloody or different?
No, she didn't report any vaginal discharge.
Did you ask? Because it's always also good to ask.
Makes sense. Yes.
Yeah. Always get a history from the patients because you are there with the patient. Remember the clinical background. So get a history from the patient, and then you can tie everything because when you have differentials, if a pregnancy test is negative, then another differential of having free fluid in the endometrium would be what?
So did the patient?
A patient with low abdominal pains, with free fluid in the endometrium, negative pregnancy test, what would be your differential?
So
And they can come with acute abdomen.
with fluid in the endometrium.
It will be infection, isn't it? Endometritis, acute endometritis. Yeah. So it's always good to get a history so that if she's spotting and that sort of thing, then you again it increases your confidence level.
Oh, thanks.
Yeah. Okay, we can proceed.
Thank you. So this next set of images show a patient who had heterotopic pregnancy. By heterotopic pregnancy means we have a normal intrauterine pregnancy coexisting with an ectopic pregnancy. So in image A, this is an intrauterine gestational sac. We can make it out here. We can see the anechoic circular mass with well-defined margins, and you can see the yolk sac within it. And then on examining the adnexon, the left adnexa, a similar gestational sac was seen, and this is the uterus, much to the left of it. So this is how you can diagnose heterotopic pregnancy. Something else, for this next set of images, we have tubal findings in an ectopic pregnancy. So in image A, it's a transvaginal scan, and it shows an extraovarian tubal mass, as indicated by this caliper. You can see the central anechoic region with the thickened wall. And then on application of color Doppler, there was, as is demonstrated here, is you have increased vascularity around this lesion, or rather this mass. And then on looking towards this side, we can see free fluid collection as demarcated by this hypoechoic region. Then in a separate patient, here you're able to see both the ovary and the gestational sac, or
So
rather
just
the
something, Doc.
yes.
In B, that free fluid is not anechoic. It has echoes within it.
Okay.
Yeah. So that makes it not just clear fluid.
All right.
Yeah, unless I'm the only one who's seeing the echoes. I think there are echoes within it. These are not artifactual.
All right. I think
But
my biggest challenge is differentiating when you're having internal echoes that are actually present or whether they are artifactual.
so then we need to look at a topic of artifacts. And maybe somebody can do as an additive a presentation on artifacts, because that's something you should cover in first year adequately enough, right? The different kind of artifacts. Because if you look at these echoes, they're different from the previous slide that you showed me. And you remember echoes, the echoes will go outside. They'll move out of, they'll not just be contained within the fluid. So they'll be arranged and they'll go out. And there's actually a name for that artifact, right? When you get those kind of, like a wave.
All right.
Yeah. And you can see it's even layering a little bit. That does look artifactual because it continues to the bar loops at the side. Yeah.
All right. So yes, to the last image, we were saying image C. Here we're able to visualize the ovary, the parenchyma, which is hypoechoic to the surrounding tissues with the follicles within it. However, right next to it, you can also see another mass, which has a central anechoic region with a thick wall around it. So this is an ectopic pregnancy adjacent to the ovary.
Right. So it will be within the infundibular end of the tube, right?
Yes.
Okay.
All right. In this next set of images, we are having both transabdominal scans. Image A shows the surgical cut through the uterus. You can make out the anterior wall, posterior wall, and the echogenic endometrial stripe, and it looks unremarkable. However, if you look at image B, you can still make out the anterior and the posterior wall of the uterus with the echogenic endometrial stripe. However, in this case, we can see our gestational sac lying further away from our endometrial lining here. And this is consistent with an interstitial pregnancy, which is an ectopic pregnancy.
Yeah, it is in the uterine conure.
Yes.
You can see it's still adjacent to the uterine wall.
Yes.
Within the myometrium there. Okay, fine.
Then this next set of images of the same patient.
Okay, Diana has raised her hand.
Oh,
Diana?
yes, Diana.
So when there's an ectopic pregnancy, in the previous image, you said the endometrium is unremarkable. So when there's an ectopic pregnancy, is the endometrium always thickened?
What I'd say from my reading, you can have a wide array of findings within the endometrium. In this case, we're seeing it's unremarkable. It can be thickened because of the progesterone produced by the corpus luteum. And also in the previous, there's a previous image where we've seen a pseudogestational sac. So you can also have fluid, free fluid within the endometrial cavity with some echoes, which could be blood. So
Thank
those
you.
are the three options I'd give. Yeah.
Yeah, the thickness of the endometrium will depend on the hormonal influence. And so if the patient probably does not have enough progesterone and all that, so they won't have good enough endometrial development. So it can be very, very varied. So it can be thickened. Sometimes it can be like in this, it looks like thin, like in early gestation, which means, by the way, like if one was following up, maybe it was a patient who had fertility issues. This would be a patient whereby they'll need to really support the endometrium because she does not have a good secretory phase type of endometrium, because it will not allow for implantation. So there'll be very many causes about the way the endometrium responds will depend on varied reasons, will be the underlying hormonal issues. And well, for the ectopic pregnancy, the response could be again varied. Maybe the cilia are not working well, their tubal intratubal adhesion, so it cannot roll over to the uterine cavity, and that is why now it will implant ectopically, or it's moved retrograde in the opposite direction from the way it's supposed to move. So there's a lot of influence that generates to result in having an ectopic pregnancy.
Okay.
Okay, thank you. Then this next set of images of the same patient, the first image, that is image A, is a trans-abdominal ultrasound, and it's showing the sagittal view of the uterus. And here we can make out the urinary bladder, the anterior wall of the uterus. But within the uterus, in the endometrial cavity, we can make out these two anechoic structures with this intervening soft tissue. And then as you go further towards the vaginal canal, yes, we can make out now the second anechoic structure. So to better visualize these two anechoic structures, they did a transvaginal ultrasound, and they were able to pick that structure is a gestational sac. It is anechoic, and then it has the soft tissue mass within it. And we can tell where exactly this mass is, because if you examine the surrounding regions, you can tell that this is the cervix. It's homogeneously progenic. And then the same can be said of the posterior lip of the cervix. And then if you follow it, you can go all the way upwards towards your uterus. And then the external cervical os, in this case, it's closed. So this is an example of a cervical ectopic pregnancy. And these are the anechoic lesion we're seeing here. That's a pseudogestational sac. Then next, this is a different case. And image A is a trans-abdominal ultrasound, also showing a sagittal cut through the uterus. And then, yeah, the anatomy is a little bit distorted, but you can make out that this is the uterus going all the way inferiorly, and then this is the vaginal canal, and then this is the urinary bladder. If you follow the anterior uterine wall, you can be able to make out that you have this anechoic structure, which looks like a gestational sac, but a transvaginal ultrasound was performed to further characterize it, and they were able to see
Anechoic. all these structures you are saying have a thick echogenic rim.
Yes.
So it is a gestational sac. So it's not anechoic. It's just the core that is anechoic, isn't it?
Okay.
Yes, yeah. But in A, you can see the double decidual sign, isn't it? The double ring sign. You can see the chorionic, and then there's also the posterior to it. You can see the decidua, posterior. Go downwards. Yes. And maybe you can also see the same in the transvaginal. So
Yes.
again, yes, yeah. So you have a gestational sac. You can see it has a fetal pole and it has yolk sac, which is echogenic.
Yes.
And and I think you're going to be doing a session looking at the different anomalies and the different appearances of the yolk sac.
Yes.
Okay.
And also how we are able to differentiate that this this gestational sac is within a region that is not the cervix. It's by examining the surrounding tissues. So if you compare it with the previous image we've just seen, there you could clearly make out the anatomy of the cervix on your ultrasound image. But in this case, you can see how the surrounding tissues are distorted. And if you combine this with the history of this patient who had previously had a cesarean section, they were then able to conclude that this is implantation on the cesarean scar.
Yeah, it looks like that, implantation and cesarean scar. And it's also low lying because you can see in the previous image, it's not in the fundus because where you want the sac to implant is at the fundus. So the
Yes.
fundus is empty,
Yes.
but it's in the lower part of the body and it's more anterior. It's eccentric, it's more anterior. And if you look at it in the transvaginal, you don't see any myometrium anterior to it.
Oh, yes.
So you're going to have a very thin, yes, because what you're seeing is actually the vaginal wall. You don't have any myometrium. So it is
Yeah.
really implanted within the scar. Surrounding it are vessels, right? And those vessels tend to develop again in the lower uterine, because you tend to have a rich vascular structure network around the cervix, as now you have the anastomosis going up as an arcuate vessels between the intermediate and the external myometrial layers.
Okay.
Okay.
Then this is another different case. So both are transabdominal ultrasounds. So image A shows a transverse, a sagittal cut. And here we can make out the anterior fundus and the posterior wall of the uterus quite well with this echogenic, um, with this heterogeneously center, which is surrounded by this endometrium that we're seeing here. And then the uterus appears bulky. Then if you
Yeah,
look,
it's surrounded by thin endometrium. So you have endometrial content. And actually, what you have is just the basal layer of the endometrium. The uterus is probably not bulky, it's probably normal size, but you need a measurement.
okay,
Yeah, if you are to measure it, maybe just 8-9 centimeters in length. Yeah,
all right.
yeah, but you have some free fluid in the POD, a little fluid surrounding it. What is
Yes.
arrowed posteriorly?
So
Yeah, that one, that structure there.
that is, they're saying it's blood around the
Blood
uterus.
clots.
Yes.
Okay. Mm-hmm.
All right. And then on scanning superior to the fundus, they were able to see a fully formed embryo, fetus, uh, which is well developed. You can see the head, the spine, this is the pelvis, and the limbs. So, surgical treatment confirmed that this pregnancy was abdominal and it arose from an interstitial ectopic pregnancy that ruptured.
Mm-hmm.
Yes.
Yeah,
So,
and okay, that is the bleeding was there, the hematoma.
yes.
Okay.
The next we'll go to miscarriages. So from undergraduate, we came across 5 different types of miscarriages, and In order for you to come up with this diagnosis, you need to marry your clinical history, or rather your clinical findings, together with your sonographic findings, so that you can give it the different terms, or rather the different types of miscarriages. So for threatened miscarriage, that's a term that is used when a pregnant woman in the first 20 weeks of gestation who's presenting with spotting, mild abdominal pain, and contraction. Um, sorry, when you have a woman who's 20 weeks gestation, they present with spotting, mild abdominal pain, or contractions with a closed cervical os, but the pregnancy itself is viable. That is a threatened miscarriage. It can still be carried
So you're
out.
saying in the first 20 weeks of gestation,
Yes,
at least I can see they've moved. Before it, I think it used to be 24 weeks. So now the first 20 weeks, the internal os is closed. The
yes,
fetus is viable, has a fetal heart rate, but there is spotting. That will be threatened.
yes, that will be threatened. And then for missed miscarriage is one that already you have the embryo that already, for lack of a better word, the embryo died, or rather it's no longer viable, and the mother is not presenting with any symptoms of a miscarriage. So there's no spotting or abdominal pain or contractions. And the cervical os would, would also be closed. So here the finding that you will get is your pregnancy is not viable. For an inevitable miscarriage, that refers to the presence of an open internal os, in the presence of bleeding. This is in the first trimester of pregnancy. And in this case, all the products of conception are not expelled. And yes, and the intracervical contents are present at the time of examination. So, in short, here it's like you're having a threatened miscarriage, but the cervical os is opened. For the incomplete miscarriage, that's a term that is used to describe a case where you have retained products of conception in a patient who's already had that process is the process of having a miscarriage is progressing. So they've probably had PV bleeding, they've expelled um, a few of the products of conception, but on doing ultrasonography, there are still a few retained products that you can visualize within the uterus. Then lastly, for complete miscarriage, that defines cessation of vaginal bleeding with no evidence of any retained products of conception, that is an ultrasound, um, or products of conception or a gestational sac in a woman who was previously known to be pregnant. So these are the different types of miscarriages. Yes, these are the different types of miscarriages that we can diagnose a patient with, and we'll see how pregnancies look when they're not viable.
Oteko has raised the hand.
Yes, Clifford? Clifford? I think it might be accidental.
All right, you can proceed then.
All right. So some of the signs of early pregnancy failure that first are these two. So you can have a crown ramp length of 7 millimeters, and on picking your heartbeat, you cannot get it. So the other sign is a mean sac diameter of 25, and you're not able embryonic pole, or rather, you cannot see it within the gestational sac. So the images to the right just show these two signs. So in image A, we can see our gestational sac with the embryonic pole. This is the yolk sac, and this is the amniotic cavity. So here they've applied color Doppler, and they're not able to pick any color within it. And this is consistent with okay, an absent heartbeat in an embryo that measures 6.5 millimeters is consistent with early pregnancy failure. In image B, we're also able to make out the gestational sac. We can see our embryonic pole with our yolk sac, but in this case, our yolk sac is calcified. And as indicated in the text below, there's faint shadowing posterior to it. And this is also consistent with early pregnancy failure. Image C. Image C shows the same. We can see our gestational sac with our embryonic pole, and then we can see our yolk sac, which is calcified. So a calcified yolk sac is a sign of early pregnancy failure. And then you can also see our amniotic cavity. We can also see our amniotic cavity. So in both of these cases, no cardiac activity was picked. And in both, these are features of early pregnancy failure. So another sign of early pregnancy failure is bradycardia and getting the cardiac activity. So first, I'll expand the image to the right. In this case, on EMOD, they were able to pick that this embryo has 69 beats per minute, and this is in a 10-week-old gestation. So in this case, having bradycardia, by bradycardia we mean a heart rate of less than 100 beats per minute. That is a sign of early pregnancy failure. It's easy to confuse maternal uterine pulsations with embryonic pulsations. Like now for this image to the left, on getting the heartbeat, they calculated it, or the machine calculated it, and it was found to be 75 beats per minute. But this was erroneous because it is seen to arise from maternal uterine pulsations. And how we can be able to tell apart the actual embryonic heartbeat from maternal transmitted pulsation is that if you look at these other structures that are cut by our line here, you can see the same pattern of disturbance cutting across all these different layers. So in our case, if you calculate using our embryo, it will give you the heartbeat, but because you're also seeing the same pattern of disturbance, you can then be able to confidently say that it's of maternal origin and not of embryonic origin. So in addition to those three things that we've mentioned, so we've mentioned a crown ramp length of less than 7 with no heartbeat, a mean sac diameter of 16 to 24 with no embryo. And we've also talked about bradycardia, that is a heart rate of less than 100. These are other additional features of early pregnancy failure. So when you examine your gestational sac and you find that its margins are irregular, and the gestational sac itself is positioned low within the endometrial cavity, and also when it has a weak decidual reaction, you can also include those as signs of early pregnancy failure. When the difference between the mean sac diameter and the crown ramp length are less than 5, that is also a poor sign. It's a sign of poor outcome. When you have an abnormally large amnion size in comparison to the embryo, that is also a negative sign, and we'll see the images in a few. Also, if you have a yolk sac that is more than 6 millimeters in size, or a yolk sac that is calcified, which you've seen, that is a sign of early pregnancy failure. And lastly, if you have subchorionic hemorrhage, a large subchorionic hemorrhage, that could be indicative of early pregnancy failure despite having cardiac activity within your embryo. So this set of images are transvaginal scans, and on image A, we can see a large anechoic mass within the uterus. This is transverse, so within the uterus, within it we can't appreciate any embryonic pole. And also something else, the margins of this embryonic of this gestational sac are irregular. On the sagittal cut, you can also appreciate the same irregularity in the walls of this gestational sac, and also we cannot spot any embryonic pole. So on calculation of this mean sac diameter, it was found to be greater than 25 millimeters, and we already say that if you have a mean sac diameter of more than 25 with no yolk sac or embryonic pole, that is a sign of early pregnancy failure. In this next set of images, in image A, that's a transvaginal ultrasound, and it's showing a sagittal cut through the uterus. Here we can appreciate the anterior wall, fundus, and the posterior wall with the echogenic endometrium. And then low lying within it, we have our gestational sac, which has irregular margins, and it doesn't have any embryonic pole within it. That's the same with image B. A transvaginal ultrasound, you can appreciate the uterus, and then low lying within the endometrial cavity, we're seeing our irregularly shaped gestational sac. So here the mean sac diameter was calculated and it was found to be 21 millimeters and without any embryonic pole within it. So that's also a sign of pregnancy failure. On image C, the other additional features that we can see here, it's a transvaginal ultrasound showing the uterus with our gestational sac, but we can see this echogenic bump on this posterior wall, and then anterior to it, we can see a heterogeneously echogenic collection that's consistent with a subchorionic hematoma. The features that are here that are not present in these other two are this subchorionic hematoma and the chorionic bump, which are both signs of early pregnancy failure in addition to this irregularly shaped gestational sac. The next, this is a transvaginal ultrasound showing our gestational sac, and in this case, the difference between the crown rump length and the mean sac diameter was less than 5. So this reduced free fluid around the embryo is a sign of early pregnancy failure. Next, this next image shows our gestational sac. It's a transvaginal ultrasound showing the uterus with a gestational sac within it, and then we can clearly make out the amniotic cavity, but we are not seeing any embryonic pole within it. So an empty amnion is also a sign of early pregnancy failure. And then this next set of images, they show a gestational sac, but here it's demonstrating the discrepancy between the embryonic pole and the size of the amniotic cavity. So if you have an embryo that exists within an amniotic sac that is too large for it, that is also a sign of non-viability. Then next we have image A, is a sagittal cut through the uterus on a transvaginal probe. We're able to make out the gestational sac. Then anterior to it, we have this hypoechoic free fluid anterior to it, which is consistent with the subchorionic hematoma. And the same is observed on this other patient. It's a sagittal probe. You can make out the gestational sac with the fetus within it, but anterior to it, we can see free fluid collecting within it with mixed echoes. So that's it for
So
the
something about the subchorionic fluid. So the
Yes.
fluid can be clear, like in image A, or it can be echogenic. So one of the things you want to say it's occupying what percentage of the of the surface of the gestational sac. So is it occupying 10%, 10 to 15% like in image A, or is it occupying 50% as in image B? Because both of them will be important, because this is will be part of a can threaten the pregnancy, and if a follow-up is done, then you want to know if there's continued bleeding. So it's nice to document how much of the fluid is there and what percentage of the chorionic
All right. Thank you. Yes?
Sorry, I had an issue with my mic.
All right.
I just want to take you back on miscarriage.
Mm-hmm.
We had a dilemma. We had a 16-week gestation who presented with a PV bleeding, and the OS was open. So, and everything was okay. The fetus was viable, and all parameters are within the normal range. So the dilemma was were we supposed to classify it as threatened miscarriage or inevitable miscarriage?
You've said the Oz was opened.
Was open, came with history of PV bleeding, fetus viable, and all the parameters are within the normal range. So
All
the
right.
dilemma is it threatened miscarriage or we consider it's inevitable miscarriage?
I'd consider that as an inevitable miscarriage because the cervical os is open. Because for a threatened miscarriage, you said there the cervical os is closed.
That is true. As long as the internal os is opened, in fact, both the internal and external, that would be definitely an inevitable. Because sometimes you can have an open internal os, but the external os is closed. So what else you need to document is the amount of closed cervix that is left, right?
Okay.
Because that can also be under a threatened abortion. If maybe there's a centimeter that is left, that sort of thing, that would be a patient who needs to be like if the cervix is incompetent, who may need to be on bed rest, and I don't know if there was still time to put in any stitches and things like that. That is something that the gynecologist would like to know.
All right. Okay.
Okay,
So
thank
the
you.
length of the remaining closed cervix should be documented.
All right.
All right.
So next we'll go to cervical incompetence. Yes?
I have a question on early pregnancy failure. I'm having some trouble differentiating a pseudogestational sac and when you have early pregnancy failure, when the gestational sac is empty. How then do you say this is not a pseudogestational sac?
One thing
And
about the gestational sac, it is central within the endometrial cavity. The amount of myometrium all around it are going to be equal, while a gestational sac is going to be eccentric. So the location, is it implanted? That's what will make you know that what you're looking at is a gestational sac.
Okay, thank you.
I don't know if it is clear about that, because sometimes when you go and you do a scan, you look at a gestational sac, it looks like it's more inside one wall than another, isn't it?
Yeah.
So that is a normal pregnancy. It's eccentric. A normal gestational sac is eccentric. It's not in the center endometrial wall or cavity. It's going to be in one wall of the endometrium. So you see, like that one is central, and it's just lined by the endometrium. There's no additional sac around it.
Okay.
As opposed to where there's actually a gestational sac, and I don't know if Dr. has shown us the gestational sac, the one which I was telling you has a double decidua. You'll see there are actually two rings around it. And it's going to be on one side of the, so you need to look at an image of a normal early pregnancy and how it is located within the uterine cavity. You see, a lot of these are all ectopic,
yes,
misplaced. Yes, yeah.
I will get a normal one.
Okay.
All right, so next we'll go to cervical incompetence. So by cervical incompetence, we mean we are defining a cervix that is not able to carry a pregnancy to term. And that can be as a result of two issues. It can be a functional defect or it can be as a result of a mechanical defect. So by functional, we mean that the cervix begins to ripen. And by ripening, we mean shortening and dilating before the fetus has reached term. So the commonest cause of this functional failure are infections, that is urogenital or intrauterine infections, or any other cause of inflammation. So that goes to say that this recurrence, because you're not guaranteed to always have an infection with every subsequent pregnancy. So as compared to a mechanical failure, by mechanical failure, we are meaning that the cervix has a structural defect, and that arises from a traumatic injury. It could be because of anything. It could be as a result of cervical laceration, of any etiology. It could be as a result of amputation, conization, curettage, or any other therapeutic therapeutic abortion. So the graph to the right just shows the correlation between the length of the cervix and the risk of preterm delivery. So these parameters here, these different numbers are the length of the cervix in millimeters. So we can see the shorter the cervix is, the higher the risk of premature delivery. However, as you head towards your 4 millimeter mark, the number of preterm deliveries have reduced. So when you're examining the normal cervix, as we've mentioned before, on a transvaginal ultrasound, you place the probe in your in the anterior fornix, and then you obtain the cervix in the sagittal view. And then in this view, you should be able to make out your echogenic endocervical mucosa along the entire length of the canal. So once you see this, you withdraw your probe until the image is clear, because you also don't want to put a lot of pressure, and also because that pressure is going to falsely elongate your cervix and you're going to get wrong readings. And then once you get a good view of the cervix, you want to enlarge the image so that the cervix is occupying at least 2/3 of the screen. And once you're able to see that echogenic endocervical mucosa, you should be able to tell the external and the internal walls. And then from those two, you can obtain your cervical length. And then preferably, you should get 3 measurements, and then you record the shortest best measurement in millimeters. So this is what we've talked about. So both of these are transvaginal ultrasounds of the cervix, and we can see the echogenic endocervical mucosa, and then we can see the internal cervical os, the external cervical os, and then these are the measurements that we need to get, at least 3 of them, and then we get the shortest possible one, and we'll take that as our cervical length. On image B, we can appreciate this hypoechoic zone, both anterior and posterior to our echogenic endocervical mucosa, and this is normal because these are endocervical glands, and it's actually a good thing when you're able to visualize them. So other than the cervical length, there are other factors that can be used as predictors of preterm birth. So these factors include things like obstetric factors. So things like the demographics, the age. They're older than 35 years of age. They're at high likelihood of getting preterm births.
Hello. Nairobi West ama Nairobi Hospital? Nairobi Hospital? Haiko Nairobi West? Si ukuje basi Kenyatta hapa Gate B utanipata hapo. Ukikuja tu Gate B unipigie. Okay.
To the maternal part. So presence of this glycoprotein indicates that there's a bit of separation. So if you combine all these other factors together with the presence of this, it increases your suspicion for that patient having spontaneous preterm delivery. And that is especially when your cervical length is less than 30 millimeters. So another thing is cervical funneling, and that refers to the dilatation of the internal os and herniation of fetal membranes into the cervical canal. So when you get funneling, that's also a negative thing to consider. Something else, the rate of cervical change. This is obtained on different visits. So let's say the patient is being seen 2 weeks apart, and you take the cervical measurements in these different visits, and you can see that the measurements are reducing with every single visit. That if that is occurring and the patient is far from term, then it's a high indicator that your patient might undergo preterm delivery. For dynamic cervical change, and how we can differentiate that from rate of cervical change, is that dynamic cervical change is in one setting. So if you're examining the patient and you examine the cervix at different times in one setting, and you see that the measurements or the appearance of the cervix has changed, or rather it has shortened, then you can conclude that patient will probably undergo preterm delivery. Other sonographic factors include things such as cervical canal dilatation, absence of the glandular area along the canal, the glandular area which you've seen, or something else is the presence of sludge or debris. Those are indicators that you probably have an infection or inflammation, and that can cause the functional defect in the cervix that can weaken it and can result to spontaneous preterm delivery. So this is a
I
schematic.
have a question before you move from there. When
Yes.
you're measuring the cervical length, you have to identify the internal os and the external os. And actually the cervix does look different, and the cervical mucosa, there's actually a change in its appearance when you compare it with the endometrium. Now, are there cases whereby you can get a false lengthening of the cervical, of the cervix, or you get spurious measurements? And
Yes.
what, yes, okay, yeah, when?
So one thing that you've mentioned, when you apply too much pressure on the cervix, you can falsely lengthen it.